Hello, everybody, and welcome to a Polestar Pilates Hour. I'm joining you today from the beautiful Polestar Life Center at Southwind Retreat Center in North Carolina. Great to have you. We've got an exciting webinar today, interactive, so make sure you get your Mentimeter ready to go. We'll give you instructions a little bit later. So let's jump right on in. What I want to do is I'm going to revisit the lumbar anatomy. I even got my little lumbar spine here if I need to pull that out for us. But I have some images that hopefully will help us understand our lumbar anatomy as I talk about the pathology. And the lumbar anatomy, we talk about 5 vertebrae. L1 up here. Let me get my little spotter on. So we look at the L1, L2, L3, L4, L5. L5 sits on top of the sacrum, and the sacrum is wedged between the two parts of the pelvis known as the innominate to make the lumbopelvic region. This would be the anterior part of the spine, and this is the posterior part of the spine. So what we often feel in our back is the spinous processes that is right here. These are the spinous processes, right? That's the bony feeling we have in the back. That's not where the spinal cord is, right? The spinal cord is deep inside. So we look at this horizontal cut of the spine, and this is the vertebral canal, the spinal canal, or the vertebral foramina. And this white thing here in front is the vertebral disc. So that's why it's important for us to understand where the anatomy is. And you've heard me do the facet dance, and somebody told me the other day, I don't really know where the facet is, but I have memorized the facet dance. So I know what movement comes from that area, but where is the facet and what does it look like? So up here where my marker is, this is the superior facet, articulating facet, and the vertebra above it would have its inferior articular facet would be inside of it. And that's where the articulation in the back happens, is in these facets. And then we have our arch, and the lamina is where we often hear words like laminectomy that I'm going to talk about today. The lamina is where the doctors will often make a small hole and break off a piece of the bone without destroying the integrity of the bone, supposedly. And that's where they go in to get into this space to be able to do the surgeries that we hear so often about: a back surgery, a laminectomy, a discectomy, those kind of things. So hopefully that helps us a little bit with some basic anatomy. You let me know if it's helpful to you. If we look at a cross-section of it, this is really looking at a lot of the connective tissue around it. So you'll hear me talk a lot about the anterior longitudinal ligament. So again, this is the front of the spine, and this is a thick ligament that runs across the front, and it covers up the disc spaces in the front. So here, this is the bony tissue, and this light green color is the intervertebral disc. Again, sort of a rubbery, cartilaginous material with fibers that hold things together and allow us 12 degrees of freedom in the disc. The disc can move in all planes of movement, including translation. And then we come to the back of the vertebral body, and that is going to be the posterior longitudinal ligament. And this posterior longitudinal ligament, again, is meant to create integrity and support the disc and support the vertebra, maintain alignment, and keep us nice and healthy in our spine. Now, if we think of that lumbar spine being lordotic, the load typically in a bipedal human is going to be more on the front of the spine. That's why that anterior longitudinal ligament is so thick, and that's why the posterior longitudinal ligament is relatively thin. Now, these holes, these circles of light that you see here, these are called the lateral foramina. This is where the nerve roots exit. This is where they go out. And this space in between here is where the spinal cord is running down, and these holes is where the nerve roots go out to provide sensory and motor to the rest of the body, depending where it's going, right? And then we see the back of it. This is the spinous process. This yellow ligament here is known as the ligamentum flavum. It's elastic. We use this one a lot in our imagery in Polestar. And then we have the interspinous ligaments that hold things together, and the supraspinous ligament. So these ligaments are all part of connective tissue. They connect into the periosteum of the bone. According to our biotenseggrity world, the bone is crystallized fascia. It's all continuous, and it's just different degrees of springiness and elasticity. So hopefully that gives a good sort of summary of that. Again, you shout out to me if the summary is helpful or if I need to go deeper. This is another topical view, sort of a cartoon of it, but now you can see the nervous system in here. So this in this central foramen, this is where the spinal cord is. And the spinal cord will have nerve roots that come off and nerves that come back into the spine. The dorsal root ganglia is this bulgy thing right here. And this is where interaction takes place and motor nerves go out, spinal nerves come back, and these are the nerves that provide both the sensory and the motor to the body. Now, if we look at this, we can see that the disc right here and the facets that are right back here, this nerve root passes right through them. And what we're going to talk about today with the stenosis is when the disc or the arthritis of the facets begin to encroach, right? They begin to press on that nerve root and actually cause nerve compression. Or we'll talk a little bit about just the dural part of the nerve, the surrounding the sheath or the epineurium that get compressed and can cause pain and radicular symptoms. So when we say the definition of stenosis, what we're really talking about is a tube that is narrowed. That's what stenosis means. So it could be a vascular structure. So if your heart has plaques, that heart artery, that cardiac artery, could have stenosis, right? So they'll put a stent in there to open it back up so it's not so narrow and blocking. Digestive lumen would be like your gut, right? Going through the colon or the small intestine. You could have a stenosis in there. So a severe diverticulitis leads to a lot of scar tissue. It stenoses the lumen, and now we have a narrowing or an obstruction in the bowel. Same thing could be true with fallopian tubes in the reproductive system. Today we're talking about the spinal cord, right? We're talking about the central and the foraminal stenosis, which is a narrowing. And that actually can be caused by a lot of different things, right? When we think of the symptoms of a stenosis, we might have some local pain, right? Causing lower extremity pain. That could be facet, dura, epineurium, discogenic, that dorsal rami that I just showed you. The ascending sensory into that dorsal root ganglia and spinal cord, that could be irritated as well. And this is going to be the nociceptive fibers coming up to the head, right, to the thalamus. And the thalamus is going to be interpreting, is this something that we need to be worried about? And then that's where the frontal cortex is going to basically say, do I need to create pain? Is there something that needs to happen to protect our body? And that's where pain is experienced, is in the front cortex. Nerve root compression, this again is narrowing of that spinal canal or that foramina. And again, remember how I said it's not always compression of the nerve. It could be compression of the sleeve around the nerve. And the sleeve around the nerve, that epineurium or that dura in the spinal cord, also are innervated and also have sensory, which means that they in themselves are a protective mechanism to prevent us from causing permanent nerve damage. So we might have pain, we might have radicular symptoms, we might have pins and needles, but we still had normal sensory to like a pinprick or to temperature. We still have normal reflexes in our muscles. We still have normal strength. That would tell me that if I'm having pins and needles down the leg, then maybe that pressure is on the epineurium and not on the nerve yet. We can think of that as being a warning, right? Pressure on the nerve, again, I said we're going to have, like, for example, I've shared with you before that I have a pretty severe stenosis. When it's acting up, I get pressure on the L4, L5 nerve root on the left and on the L5S1 nerve root, and it causes a foot drop. So I have difficulty lifting my foot up. I trip over my foot sometimes because of actual motor loss. Most of the time, though, I just have pain, and then it's the nerve sheath that's telling me that it's painful, right? And this is probably more common than not. We hopefully we're treating things before they get too far to where there's actual nerve damage. Now, other things that can be affected, spinal cord, we looked at that disc. The disc can be herniated, putting pressure on that nerve root. I've seen patients with what are called spinal cysts, or they have a tumor, a cancer, or benign tumor in their back. Another common word that we love to say, and nobody really understands what it is in layman's terms, they get scared when they hear a doctor say it, and that is spondylolisthesis. And the opposite of that would be retrolisthesis. So it just means that the stability, the structural stability of the vertebra between each other, it actually shifts forward, right? And you lose a little bit of that anterior stability. Well, shifting that forward is going to narrow that space in the spinal canal and also in the lateral foramina. So it also can be a common cause, or is a common cause, of stenosis and stenosis-like symptoms. All right. So again, we're looking at the anatomy. Just to refresh it, let's go right into what we call false positives. So when we look at a normal population, a population that's never had symptoms in their back, they did a study and they were looking at different types of pathologies. So the light sort of green, blue, aqua is disc protrusions. Now remember, these are people that have never had symptoms. And on the side here is age, so 20 to 29 all the way up to 60. And then below, you're looking at what percentage of them, of this group, this 1,000 subjects that never had back pain, actually had these pathologies. So disc protrusion, even in like my age bracket, over 60, 40% of them that never had pain had significant disc protrusions. Over 80% of them had disc bulging, and 100% of them had problems. I don't know where 120 came from down there, but 100% of them had facet arthropathy. And that is basically arthritis, right? And so you can even see down, for those of you that are middle age in your 30 to 40 years, 20% disc protrusion, 35% disc bulges. So you can see that these pathologies exist and they don't necessarily correlate with the pain. These people never had pain and they had severe pathology. So when somebody has pain and they come in, we immediately jump to the conclusion that just because they have some of these signs in their MRI findings, that they actually might be, that it's being caused by what they're seeing in the MRI. In reality, it might not be. And that's what we're going to talk about today with this case is how do we make sure that we are respecting what the MRI is telling us, but not making all of our decisions on what the MRI is telling us. Here is an example of an MRI showing a disc bulge. So this white spot here, this is the actual spinal cord. And then these white sort of airy things coming out the side, those are nerve roots. And this darkness underneath the red, that's a disc bulge. So that disc bulge is pushing into the canal and this foraminal space. So this person, if this was their right side over here, it would be pushing on that nerve root, L5S1, probably causing problems down into the foot and the ankle. Okay. Here we can see that same person. This is the disc bulge, lateral and the spine. And you can see how, as this is two slices of an MRI, this is also an important point for me to make. This slice is more central and this slice is more lateral. So more lateral, we're seeing where that disc bulge or that prolapse, same kind of word, is putting pressure on that L5S1 nerve root that's going to come out through this space. So this person has that same problem that we saw in the previous slide of where that disc bulge, and if we go back to that slide, we can see how it's off to the side and that disc bulge is putting pressure, and that's why it's going to be worse over to the side. And they might have symptoms and they might not have symptoms. When we look at bony structural, this is central stenosis. That means the central canal. So there's the normal canal, nice wide open, good foramen on the side, good height from the disc. There's something called congenital stenosis. So some children are born with a bony malformation that is narrow around the spinal cord. And that might manifest when they're young. It might manifest when they're older. It might never manifest. Degenerative stenosis, this is sort of what I deal with in myself, and the client we're going to talk about is more this kind of stenosis. But the facets themselves, this is where the facets are, they become arthritic and they hypertrophy. Hypertrophy means they grow, right? The calcium grows into the spinal canal and into the foraminal space. This is the most common type of degenerative stenosis. So usually it's an overuse kind of arthritis of gliding and rotation excessively, like at L4, L5, or L5S1. And that hypertrophy of that arthritis actually encroaches on the central canal and on the actual foramina. Again, keep me posted if I'm going too fast, too slow, boring, exciting. I got to make sure you guys are understanding it. This is an example of stenosis again, but up higher levels. So here you can see this is the facet. This is the disc. The facet hypertrophies on these two levels, right? Up here, not so much, but you can still see some hypertrophy and degeneration there. And this is causing, this is an L3-4, L4-5 coming down the spine. This happens to be my back. So treatment of stenosis. In the medical world, treatment of stenosis typically is going to start with some kind of pharmaceutical. If you're having the symptoms, I should say treating the symptoms of stenosis, which could be centralized pain as well as radicular pain. Radicular means it radiates down the leg or into the buttocks. We often will see a physician. The physician would prescribe an anti-inflammatory and preferably a non-steroidal at first. And if that doesn't work, then they'll go with a steroidal like prednisone, a Medrol pack, a cortisone. From there, if that doesn't work, it's injection. So in my case, I'm sharing my medical history with you here. I get epidural like every 4 to 6 months right now to try to manage some of the symptoms of my stenosis. The final stage of that is if it does not resolve with medication, calming the inflammation down, or an injection, calming it down, from the medical perspective, the next step is surgery. And I'll show you what some of these look like. So, of course, NSAID are going to be things like ibuprofen, naproxen, Aleve, those kind of things that we would be taking. There's some longer lasting ones that do not hurt your gut as bad if they work, right? Some people are not allowed to take them because of they're on blood thinners or they have other pharma that's contraindicated for that. Prednisone or any of the steroids is the next one. That's a little bit stronger, but it has a lot of side effects, right? It'll affect the hormonal part of the body in many ways. It can increase hunger, it can decrease metabolism, it can cause changes in sex hormones, it can increase your blood sugar. If you're diabetic, that's not a good thing. So there are some contraindications with this. You can't just keep getting Medrol packs and or getting injections. This is sort of with injection. People always wonder, like, well, what is a facet injection and what is an epidural? So on the left here, we have the facet injection. And the facet injection is going in between those facets I talked about where there might be pain coming from the structure itself, the joint, right? We think of the facet as the joint of the spine. And it'd be like, oh, my knee hurts, I get a steroid injection in my knee. My shoulder hurts, I get a steroid injection in my shoulder. If that's the case with your back, that's typically going to be a facet. If it's a nerve root issue or a central canal issue, they will do what's called epidural. Now, we know of epidurals for things like postpartum with pregnancy. They'll do an epidural that is more of the anesthetic epidural that's going to cause sort of a paralysis and numb all the pain from going up into the brain. And so it's easier to have the baby without having all the discomfort or pain with postpartum. This they actually do go into and between, and it's often guided by CT scan or by fluoroscopy, that they go in with a catheter and they do not touch the spinal cord. What they do is they bathe the dura with the steroid and often with a long-lasting like Marcaine, a long-lasting analgesic. I don't know if they call it analgesic, but Marcaine. And that is the pain, causes, so there's no pain. And the steroid usually takes a couple days to a week to start working to reduce the long-term inflammation of these tissues. So that's the facet injection and the steroid injection. And then finally, we talk about minimally invasive surgery. I'm not going to go into reconstructive surgery today, but just briefly, they will make a small fracture into the lamina that we talked about. They have a cannulus that goes down to protect everything, and then they can come into this space and they're able to remove the offending disc, or they can shave down a little bit of the facet, whatever they have to do to create space for that nerve root to be free. And that's the most common surgery for these type of problems if there are not actual structural problems. All right, so before I jump into the client that we're all going to play with today, and our timing's perfect, there's two questions that came up. Irena said, what is the difference between the disc protrusion and the disc bulge? Which one of them is a slipped disc? Okay, great question. First of all, we use that term slip disc sometimes sort of carelessly. There really is no such a thing as a slipped disc. Remember that the inside the disc, you can even see it here on my model, and you can see that red thing, that would be a disc protrusion, right? So the nuclea pulposa of the disc is the jelly inside this fibrous disc. And that fibrous disc is the lamina of it are going in all different directions in a healthy disc. And what happens is with deconditioning and heavy load and a lot of forward bending, we actually start to break through those posterior fibers of the annulus of the disc. And then that gel starts to protrude and push through like a balloon. So to answer your question, a disc protrusion or a disc bulge are the same thing. So we'll say a disc protrusion, disc bulge, same thing. Prolapse, even a little bit worse, right? You've lost height in the disc. So that height loss is going to cause narrowing of the foramina, and it's going to put pressure on the nerve, okay? No such a thing as a slip disc. The disc is fixed. It's not going to disappear. So great question. Good clarification on that. Sarah Edwards, how you doing? Good to hear from you. To clarify, can a stenosis in the lumbar spine result in radicular symptoms such as foot drop or weakness on one side of the body? The answer to that is absolutely. Anything that is putting pressure or narrowing the foramina, narrowing the central canal is referred to as a stenosis. The stenosis can be caused, right? And that narrowing can put pressure on a nerve and cause radicular symptoms, neurological symptoms, sensory systems, numbness of the foot symptoms. It could be caused, though, as I mentioned earlier, from a bulging disc. It could be caused by a arthritis of the facet. It could be caused by the spondylolisthesis and instability where one vertebrae slides forward a little bit. It could be caused by a cyst that forms in there. Sometimes cysts form inside the spinal canal. It could be from a tumor, either malignant or non-malignant, meaning cancerous or not cancerous. Trying to think of other things that might cause that, but or just remember we said the congenital too. So somebody is just born with a real narrow foramina, a real narrow central canal. Good questions. Colette Rarong, I hope I said that right. How can you tell when to do the local facet injections? Is it when the pain doesn't radiate to the limbs? So also great question, Colette. The way that I often differentiate it is the levels that I talked about. And again, we haven't talked about what we're going to do as physical therapists and Pilates teachers. We actually have a lot that we can do before people need to have injections, and definitely before they might need to have surgery. But let's talk about the injections. If in the medical world, if you're not responding to the medications and you are a candidate, so let's say that your MRI shows that you have a stenosis. It shows the narrowing. The first intervention the surgeon will do is probably order an injection or an epidural. If that epidural works and it decreases the pain and the weakness and the loss of function in that lower extremity, then it also is diagnostic. And what I mean by that is you don't want somebody doing surgery in an area that is not actually causing your pain. I'll give you my example. In May, I had an MRI and I was in excruciating pain in my knee and my foot and ankle. I had foot drop. I could hardly stand up straight. I was in terrific pain. And I saw a friend of mine that's a very well-known neurosurgeon in Miami. They did the testing and they saw that I have severe stenosis of L23, L34, and L45, 3 levels. But the symptoms I was feeling were correlated with L34. So the doctor ordered an epidural for L34 with heavy emphasis on the left foramina because my pain was all on the left side. I wasn't too hopeful. I was thinking that it really was my knee, it really was my ankle, maybe something post having the hip replaced in December. I got the epidural, and 95% of my symptoms in my left leg were gone, including the foot drop. And it just was like a light bulb going off and going like, okay, in this case, the stenosis really is at that level is causing the majority of my pain. So I don't need to have multiple levels fused. I probably just need eventually have a surgery that's going to be a little roto-rooter, as we say, cleaning up some of the bony scar tissue in there. And so that's why we talk about this idea of the injection is good relief. It's temporary relief. It gave me relief about 4 or 5 months, and then I had to have another one. But it was spot on the diagnosis of this neurosurgeon. He was spot on. Let's see, I have one more question. I'm going to go into the case study. This is Rosanna. Good to see you, Rosanna. Neck stenosis, if you have time. So the neck stenosis is exactly the same thing. Exactly the same thing, but now you're looking at nerve roots that are going to feed the upper extremity and the shoulder, right? So it's exactly the same thing. So it could be a disc, it could be arthritis, it could be a cyst, it could be any of those things that are narrowing the nerve when it comes out of the foramen of the spinal cord itself. And that's going to affect, we talk about 4, 5 in the shoulder, 6 down into the finger, right? 7 in the back of the hand, 8 in the little finger. So we can identify where the neural symptoms are with what level there might be a problem. And if stenosis is the problem, it's exactly the same in the neck as the low back. And the treatment is exactly the same. So great question. All right. Last question I'll take. Yvonne, this is a great question. So can neck stenosis cause a frozen shoulder? Not typically. I haven't heard of that relationship. I won't say it can't. I won't say it hasn't, but it's not high on the differential diagnoses. It's usually hormonal or an injury past or scar tissue and certain events that are causing that capsulitis. It's not typically neurological coming from the neck. But I'm going to go check. I'm going to ask somebody I know who would be a good authority on that question, Yvonne. And then Catherine Connor, you guys see, I love you're asking me questions. This is so good. Migraines. Migraines typically is a vasoconstriction or dilation problem with the arteries in the head. So things like, you drink some caffeine and the migraine can go away, but there's lots of different types of migraines. You can have a headache that is coming from like a C1, C2, C3 that can come up and cause a headache. I wouldn't categorize them as migraines. I would just categorize them as headaches that are coming from the upper cervical, and definitely can have headaches from that. All right, let's go into this client case. So this is Jenna. Jenna is a 54-year-old patient experiencing acute stenotic symptoms, including localized electrical shocks in her low back, with difficulty bearing weight on her right leg, especially when transferring from sitting to standing. That's the worst part for her. Employed as a senior manager at a bank. She's not really sure of how it started. She is doing some heavy lifting in her gym, a little CrossFit kind of training. She said to me the aggravating factors were sit to stand. She had also trouble in bed, like moving around in the middle of the night. It might wake her up if she changed positions. She's a side sleeper. Bearing down, so like having a bowel movement or lifting something heavy or coughing would often incite her symptoms. Lifting arms overhead was a problem. Breathing deeply was a problem. And going up and down stairs, she had a hard time on that right side. All right, did I just pass one? All right, here we go. So when we look at the subjective insight, you know, the questions that I ask my patients, and this is now her coming to me as a physical therapist, and I already have the information from, you know, the community doctor. And I asked her, what do you believe you're able to do or not able to do? And she said she's not able to do community ambulation right now. So just going to the grocery store was hard. Stairs was hard. Definitely not participating in her training or cycling, and definitely cannot recreate or travel. And then asking her, what do you believe prevents her from that? She says these short spurts of severe electrical pain in back and right leg, especially when changing positions, difficult to stand for longer than 10 minutes. So she's fitting right into a lot of the signs and symptoms that we would see subjectively for stenotic symptoms. And again, doesn't mean that it's super severe. It just means those are the symptoms that we're seeing. So before we start doing our assessment, our physical assessment, I want you, based on the subjective information up to this point, to hypothesize what you think Jenna needs the most right now. And it's okay to do that. And it's okay to be wrong. It's just a nice way of, you know, seeing where our brains are. And this is a written one, so just write in what you think. But what do you think is the most important thing that she needs right now? So we'll just take a few minutes and have you enter that data. And a lot of times this is helpful, you know, when you're talking to them in the subjective and you're asking them questions and they're giving you their information, to be able to hypothesize what are the possibilities that could cause this, and what is she really saying that she needs the most? What is it that she really needs right now to be able to feel human? Yeah. I see some good answers popping up here. Keep them coming. So we've got over 140 people on today. So just let's play together. Let's get this thing cranking so we can see what you're thinking. And it's okay to think the same thing as others. It doesn't have to be original. I see a lot of things from the psychosocial aspect of empathy and being a good listener and listening to what she's saying, to looking at pain relief. Some of you would see that pain relief through pharmaceuticals. Others looking at quality of life is what she needs to return to. Yeah, this is good. Give you another minute. Yeah, I'm digging that. So I always think, without a doubt, no matter what we do, in the Align the World tour, we talk a lot about this, because we talk about how do I align myself, and then how do I facilitate alignment in others, right? And when we're present as the practitioner, as the Pilates teacher, we are the ones that are to listen, to try to accept where they're coming from and acknowledge what they believe is going on in their body. And that's definitely true right here. Other things that I see in here that are very important is, to some extent, we're going to have to create a safe space for her to move and regain confidence. Right now, her fear of moving is probably paralyzing her as well. Like, nobody likes that heavy electrical pain that comes from putting pressure on that nerve root. So let's keep going. Some of you think like the medical diagnostics, the imaging, and those kind of things, and you're exactly right. Let's see what's going on here. So in her objective test, like this is what the doctor sent to me. She had x-rays and an MRI that showed a moderate stenosis at L4, L5, and worse on the right. The peripheral neurological tests are all negative, both sensory and motor, so there was no nerve damage. So again, if you're just thinking in your mind, where is the pressure? Is the pressure on the epineurium, on the sheath outside the nerve, or is it on the nerve? And the answer that would be on the sheath, right? There's something encroaching on the sheath, or the sheath could be inflamed into the bony structures around it. It could be either way. but something is irritating that sheath, and that's why she's having the pain and the electrical shocks. But her motor, her strength, her reflexes, her sensory are all normal. The physician diagnosed her with acute stenotic pain at L4-L5 on the right foramina affecting the nerve root. The treatment that the doctor did was gave her a Medrol pack, a corticosteroid treatment, right? So a lot of you are right on the money, right? You were right on the money of like getting maybe a steroid or something like that when there is a neurological problem. Our job as physical therapists and Pilates teachers, we're never going to prescribe medicine. We're not going to tell our patients to get medicine, but we can have the knowledge to know what kind of things help people with these type of symptoms. So then she had her physical therapy evaluation and treatment, and the primary focus was behavioral modification. So some of you were right in that area too, of like teaching her how to sit to stand and how to walk and how to do her daily activities without incurring that pain. That might be something like just moving slow. Don't be in a hurry to stand up so fast and then get that shock electricity. Stand up slow and let the weight and that fluid gradually change inside that disc space or inside that foraminal space so that you don't have the severe pain. 2 was reducing inflammation. So we used our different, modalities and things. Microcurrent is nice for helping to reduce that. Myofascial release to secondary joints and tissues, looking at hip flexors, anterior thoracic, getting her to stand up straight again, open hips to minimize the extension force in that L4, L5. That's what we're trying to, if you think about it, if your hips are really, really tight in the front and you stand up too fast, the hip flexors are going to pull the spine forward, which is not always a problem unless you have a stenosis that is irritated. In her case, it's irritated. So we wanted to open up the front of those hip flexors so she had lots of space, could stand up nice and tall without feeling the compression in the disc. And then joint mobilization of ankles, hip, and thoracic to try to increase other joints that could be mobile so that it wasn't only moving in L4, L5 in her strategy. And this is something very common. Remember, I always talk about being a lazy Pilates teacher. A lazy Pilates teacher could focus on thoracic mobility and breath, could focus on hip extension and internal external rotation with our exercise repertoire and ankle dorsiflexion. If you did that, you're probably going to resolve 50 to 55% of a lot of the orthopedic problems out there with one shot, just hitting those 3 things. This is definitely true with stenosis. Distribution of movement equals distribution of force. We want to minimize the force at L4, L5. Bottom line, we want to minimize that force. So the outcome in her physical therapy for those 6 weeks was reduced pain in the low back by 80%, reduced incidence of electric shock by 95%, which is pretty good. And she was back to her daily activities and her work. She was not back to her recreational status. And so I am referring her now in this situation to you as a Pilates teacher. So I'm referring to local Pilates teacher to focus on movement strategy with safety precautions to avoid future irritations. So now we get to stay interactive with this. So make sure you got your Mentimeter going. Let's keep moving through this process. The results of the Pilates teacher interview, when we talk about what you believe, was that the physical limitation was decreased thoracic and trunk mobility in all planes, guarded and deformed standing posture secondary to pain and fear, right? So probably like a posterior tilt to tucking under to try to avoid closing the space in the back. Psychologically, fear of returning to exercise in the gym and fear that pain will return and that she might need surgery, right? So those are some of her fears. Those are some of the physical limitations she has. And then functionally, prolonged standing and walking still a problem. Ascending, descending stairs is still a problem. Overhead activities is still a problem. And she has not dare return to the gym or her recreational activities. So with that being said, let's ask you, what functional tests would you want to do? This is sort of like our Polestar assessment tools or screening tools, or if you're a physical therapist, what kind of functional tests would you do with Jenna at this stage of the game? While you guys are answering that question, I have 2 more questions that have shown up in our Q&A that I'd like to answer. Rosanna is asking, is the peripheral test same as nerve conduction test? And the answer to that is no. They both give us information on that. The nerve conduction test is electromyography test where they actually put electrical stimulation on you, and they want to see if there is actual nerve damage, right? Where what we're doing from a physical therapy standpoint is we're actually testing sensory with maybe a little pin or light touch or deep touch. And then we're testing the motor with reflexes and manual muscle testing. If those fail, like the manual ones of me testing, I would then send to a physical medicine doctor or a surgeon that would refer them to electrophysiologist that would do the nerve conduction study. And the nerve conduction study would be indicative that there really is nerve damage happening there. So good question. Sarah has a client, has tightness and pain around the top of her thigh, can't lift the leg from supine without pain, and then weakness, foot drop on that side, interest in the relationship with hip flexor and stenosis. Well, there's a very powerful relationship with that. Keep answering those questions, guys. If you think of, here's a spine from a lateral view. This is the front of the spine. And the ilius, the psoas major, is going to attach to the superior vertebra of the lumbar spine all the way up in the side to the lower thoracic. It's going to go actually through the diaphragm. So if the hip flexor is tight, it's going to create a shear force. It's going to pull the spine forward in that force, and it's going to cause an extension where that stenosis is. And that might be why she's having trouble. She can't maintain enough stability around the spine, and that's causing her to have a little bit of shear force or a little bit of closure in the foramina. I think there's a lot of debate on that in the scientific field as to whether there actually is a shear force going on there, definitely in the biotensegrity community, but it definitely could cause closure around that foramina, and that could be causing some nerve pain. Julie Mahoney says, how about a client who's hypermobile already in ankles, hip, and thoracic? And they're going to be, actually, believe it or not, a little bit easier to treat with a stenosis if we can maintain axial length, right? We don't want them to compress because we can get a little more distribution and movement that is going to minimize the amount of stress going through the irritated segment, especially if they have some thoracic mobility. Catherine Connor, stenosis versus sciatica. Sciatica is a result of stenosis. So if the canal and the foramina are compressed, then it's going to put pressure on that nerve. And if that nerve belongs to the sciatic nerve, so L2, 3, 4, 5, S1, if those nerves, any of those are stenotic impacted, then you're going to feel sciatica. But you could also feel sciatica from obstruction at the piriformis, or where it passes through, or at the where we sit. Sometimes it passes through underneath those muscles in the hip. So we can create compression on that sciatic nerve anywhere in the chain. Stenosis is one way that happens. All right. So I'm looking at your test here. I see 25 responded out of 140 plus. Let's see what we have here. So hip hinge, sit to stand, balance test, squat, swan, goalpost, long sit, loving it, sit to stand, hip hinge, gentle toe touch, squat, prone press, heels, femur arch, prone press up, good, squats, goalposts, sit to stand transfer. I'm looking also in the chat. I see a lot of you putting things in here. Full squat, breath, good, front roll from standing. And we'll talk about the contraindications and precautions a little bit later in this, as we're moving through this. Rib capacity, sit to stand, range of motion, rotation of the hips, above the hips. Good stuff. Chest lift, rib expansion. All right. So this is what I came up with, and you're all right on the money. Like, look at this. Goalpost, sit to stand, lunge, squat, modified swan, prone knee bend. Even some of the names you use are the same exact test, right? Even if they're not the same name that I use, you're looking at the same test. So we're looking at goalposts. We want to know, does she have thoracic mobility and shoulder mobility? What's her strategy? Does her strategy, or is it a structural restriction that forces her to go into extension in her low back when she lifts her arms up? sit to stand. I want to see if something actually is causing that, right? I want to see how her body behaves, or what's her strategy. Maybe she doesn't have a very good strategy of sit to stand, like scoot to the front of your chair, lift your chest up, have your feet underneath the center of gravity, and stand up nice and slow. Lunges, this is going to tell us what's going on with those hip flexors. If her hip flexors are really, really tight, or imbalanced is probably a better word, imbalanced with her core, then she's not going to be able to keep that hip opened on the back leg going down into her lunge. That's going to give us a lot of information if she has to go into a anterior tilt because she doesn't have that hip extension. Squat, she wants to go back into the gym, so that's a functional test for her. She wants to be back there. That's probably where she got hurt. So I'm also interested to see what her strategy is. If she doesn't have ankle mobility, do I lift up her heels and all of a sudden she can do a squat and she no longer is irritating that nerve root? Modified swan, I'm really looking at the upper thoracic. I'm not really looking to increase any extension in her lumbar. So big disclaimer there. Prone knee bend, again, I'm looking at all of those hip and knee and lower extremity kinetic chains, looking to see if those fascial trains are too restricted in relationship to her hip extension and lower extremity extension chain. So these are just some ideas. And again, there's not a wrong answer on this necessarily. So now, what do you believe could help Jenna regain her ability to return to the gym, right? Without pain or fear. Where do we go from here? This is where we make our big bucks. If we can get Jenna back into the gym, living the life that she was doing prior to the irritation of this acute, and it's not like it was ongoing, and it's not like the stenosis just came on one day. It was there. She did something to irritate the nerve root. It's not severe, not going to need surgery. She's already feeling much better. How do we build her confidence and get her back in the gym, right? So I'll leave that up to you to answer that question on Mentimeter. And we do have like 2 more Mentimeters, so don't turn it off. While you're answering, I'll continue to answer some of your questions. And I love you asking me questions. This makes it very, not only entertaining for me, but more meaningful. Irena French said, from experience and observation, majority of people have pain in their right leg. Is that your experience, and why would that be? I don't have the same experience, Irena. We've joked often about, if you are south of the equator, you tend to have more right anterior pelvic torsions, and if you're north of the equator, you have more left anterior pelvic torsions, and the water in the toilet spirals a different direction on the other side of the equator. I have not seen that it necessarily one or the other. There might be a relationship that we see, Irena, with right-handedness, left-handedness. I'm not sure. I mean, like for me, almost all of my stenotic symptoms and sciatica are on the left side. So I could be abnormal, which would not surprise me. All right, let's see what you guys are saying. Successful movement experience. Yes, with Pilates will give her the confidence she now lacks. Biomechanical counseling. Love it. Encourage her to move slowly and work up to increase load. Good, graded load. Oh, you guys got all the right answers. Help her to have awareness of her own body, right? So her own internal locus of control, super important. Support her to be more aware of internal feedback. Yep. Positive movement experience. Very good. Strengthen her teaching her new strategies. Yes. So behavioral change. Awesome. This is great. Let's keep going, and I'll show you what, you're right on the money for this. So here's a little bit of insight for Jenna's situation. Jenna's restriction of thoracic appears to be much more related to behavior at work. It's not structural. She's over her computer. She sits in a chair all day. It's more behavioral, and you're going to be able to make a huge difference on that. Fear of injury and pain can completely change the movement strategy. So the goal is to shift Jenna's paradigm to movement equals relief and joy. This is where successful movement experiences without pain, or successful movement experiences that exceed her expectation, play a big role in her getting back, right? So here we go. How can we help her regain her thoracic and hip mobility, and re-educate her spine mobility strategy? So now let's get a little bit more into the techniques that we're going to be using with her, what exercises, how do we educate her to be more self-reliant? How do we get her able to, take the responsibility of her own body awareness and give her the tools to do that. While you're doing that, we've got a couple suggestions in here. Catherine Connor talks about aqua exercise, water walking. Yes, what does water do? Water grades load. If we are slow moving in water or we're using the floats, it's very assisted. There's almost no gravitational force on us. If we move fast in the water, we can create massive amounts of resistance, which also is cool. So we can grade the load, and Pilates does that, right? Water is a very pure, natural form of it, but Pilates also does that. We have something from somebody, anonymous attendee, says, how would treatment differ if her stenosis was severe and her goal was to avoid surgery? If it's really severe and they're having neurological signs, there are ways that we can potentially work around that, right? We can get better movement in other parts of the body. We can minimize stress at the level that that person is having stenosis. We can see if that works. We can combine that possibly with some epidurals from the medical community. And in the myofascial world, I was working with Zoga, with Vocek, and he does some amazing things that sort of modify tissues and bone mobilization and things. So there are some treatments out there that are non-surgical for the more severe levels of that I would say we could look at before you go surgery. And then also within the surgical field, there are things that are very minimally invasive, very non-threatening. All right, I'm looking at your answers here. This is great. Breath and mindfulness, of course, prone press-up exercise in the lateral barrel. And again, remember what the precaution that we have with Jenna is to avoid any kind of extension at the L4, L5 right now, because that would cause a potential narrowing. So flexion is not a problem, but it's the return from flexion that often causes what we call a rebound symptom. Like if you've been sitting for a long time and your tissues adapt and you stand up quickly and you have a stenotic level, you have a disc herniation, that can be the most painful time, is going from that comfortable flexed position into a neutral position. So we just have to be careful of that. Posture work, align pillow under her lumbar. Yes, it's a nice way to get her to have some awareness of that. Making sure that she has her own home exercise program. We want to know what she's feeling when she's doing it. I love that somebody mentioned Eve Gentry, right? Eve Gentry was the master of pre-Pilates work. She created her own work that was much more rehabilitative, and how to do things that created more mindfulness of our body, of neutral spine, of where our movement comes from. Pelvic tilts, yes. Segmental bridging, yes. And again, if you can think of the concept of distribution of movement equals distribution of force, think of, I don't want to necessarily move L4, L5 anymore, probably moved too much already. What does T11, T12, L1, L2, what do they look like in her flexion strategy? What do they look like in her extension strategy? What do they look like in her rotation strategy? So we can definitely start working on that and getting a little more particular of her having awareness that she can move from other parts of her body. A lot of her not movement is either behavioral or fear. So let's keep that movement. And we see this all the time in Pilates, where people come in, severe stenosis, disc herniations, all kinds of pathology in the lumbar spine. And we don't take time to think of changing their strategy. They even go and get surgery and they come back, and then 2 years later, they have the same problem, but the level above or below. And it's because we didn't change their strategy. With her, if we can change that strategy, we can get a head start. I also see some good stabilization work here. Dead bugs, swan prep, pre-Pilates exercise that she can do at home. Love it. Footwork, chest expansion. Yes, yes, yes. Femur circles to get the hip mobility. Foam roller to get that thoracic mobility. Some good stuff. Excellent, everybody. All right. There's two more of these, and we're like the last 2 minutes. Last minute. Here we go. So what principle of movement would you prioritize? And it should be for Jenna. Sorry. I don't know how Carrie got in there. But just pick the principle of movement and just prioritize your number one. While you're doing that, there are things we can do after the fact once the client has symptoms. But as an instructor, What should we be doing, be aware of to reduce the possibility of being one of the causes? And that was what I was just mentioning, is to avoid extension or anything that would be symptomatic or cause symptoms inside of our client's back. Like the biggest no-no with stenosis is to go into extension, right? Because that's going to, at that level, it's going to provoke it. What I try to do is, if I can find alternative parts of the body that can go into extension to allow uprightness, like thoracic and hip extension, that can take off a huge amount of stress of extension in the level that's a problem. Rosanna asked, if coming into us, we know she has trouble with arms overhead, would you do a modified goalpost, or you'd still would like to see that how high she can go? I still would test it. The goalpost isn't going to cause trauma to her, but it would tell us where her symptoms begin. And I want to know. If I know where she'll get like that, okay, I know that you only can get to here, and we're going to work to get that shoulder girdle open with a different strategy. All right. Now, the truth of the matter is, with her, regarding the principles, I'm thinking breath as my primary one to get things sort of organized with her, and then distribution of movement, and then control of that movement so that she feels confident with it. Then I would go into making sure that her alignment started to improve. I wouldn't try to do her alignment first, because you still might have that irritation, that nerve root, and then tie it all together, movement integration. So they're all right. I'm just telling you what I would do. All right, here's our summary, and I think this is where we'll finish up. But focus on hip and thoracic mobility, focus on creating positive movement experiences without pain for Jenna, overhead activities, walking and standing without pain, gradually return to loaded activities. You guys did such a great job of choosing all of these things. Structural limitations, thoracic restriction. This is where you guys talked about doing things like the foam roller and doing some blocked abdominal and low back activites. Myofascial restrictions in the chest and the hip. Strategic limitations, confidence and ability to move without pain, and discover the gym again. That would be my main goal, is to get her to start having some successful experiences in the gym. All right, I think that concludes our session for today. The time is up. It has gone quickly, and as always, I really appreciate it when we have your participation. And if you have more questions, you can shoot them to us, and Melissa and Gabriel do a great job of making sure that this event runs smoothly. I want to thank everybody, especially Polestar, for making the Pilates Hour something that we've been doing now. We're in like 250 sessions that we've done. I hope that you enjoy them. Please share them with friends. And just as far as our going home, our goal in Polestar and with me is to bring the world physical, emotional, and spiritual alignment. Remember that knowledge does not require a license. We live within our scope of practice. And above all things in our crazy world, be kind. Have a wonderful weekend. We'll see you next week on the Polestar Pilates Hour.